So, from the beginning, so it's quite interesting listening to Kat talking and realising that in some ways veterinary laparoscopy has a lot in common with medical laparoscopy from around about 1929, I think was where I got to, and I thought, yes, we're still doing that. In all truthfulness, probably we are in around about the 1980s in terms of where we are in relation to the human side. And that's to be expected, I would say. It would be nice to think that one day we might catch up, but I'll come on to why we might not. So this is the setup that we have at Towcester. So we've got nice operating theatre, all the kit, we've got our screen there, and it's a very nice setup. Going back to medical laparoscopy, it's quite interesting why they arose. The human abdomen is quite big, and therefore if you want to get anywhere in it, you actually have to make quite a big hole. And there are quite a lot of major surgeries that they do a lot of, like gallbladder removal, cholecystectomy. That's right up in under the rib cage. Actually trying to get there is so difficult. And so it was one of the reasons why it very quickly took off. As soon as they had the technology, you had something that could do the job so much better than what was there already. The other bit is colorectal cancer. You've got tumours down here. You can't get down there. Therefore, again, as soon as you had the technology, it was absolutely brilliant to be able to go in there and you could do the job so much better than anyone had been able to do it before. So you had this so much better visualisation, you could get in there, you had smaller scars, everything was so much better, and that's why it became so quickly the gold standard with a very, very strong evidence base for its use. But is this true for veterinary patients? Because remember, in the human field, it was driven largely by two particular types of surgery that were so difficult to do conventionally and so much easier to do as a laparoscopic procedure. So this is your human abdomen, and that's where your gallbladder sits, so that is right up in underneath the rib cage. This is where you get the colorectal cancers, and again, it's just a difficult area to get at. So, as to, is laparoscopy going to be the way forward for our veterinary patients? Well, it's difficult to understand whether in guinea pigs it's ever going to have a huge future, because you can get in there. The access is much less of a problem. If we go to the other end of the scale with horses, that is definitely a huge growth area at the moment. Why? Because you've got this huge abdomen, that access is so difficult. You get in there with a scope and suddenly you can see things, you can access things that it's so difficult to do conventionally. And of course our dogs and cats come a little way in the middle. So it's going to depend what we're trying to do when we get in there, and I think this is the other thing. There's this feeling that laparoscopy is the answer to all problems. You know, everyone talks about it in the human field. Keyhole surgery, it's brilliant. But quite frankly, if you're trying to remove a tumour this big, and that was one that was removed from a chap in India, if you're trying to remove a tumour that is the size of that, there is absolutely no point trying to do that as a keyhole procedure. You might be able to get in there and see the tumour, but you've still got to make a hole that big to get it out. So you've always got to be thinking, what am I trying to do once I'm in the abdomen? And so obviously things like taking little biopsies, absolutely brilliant. So there are certain criteria, therefore, that will make you think, yes, this is a good idea. So if your scope and camera can improve your visibility, if it can improve your accessibility, yes, it's a good thing. Once you're inside the abdomen, it's true to say, once you're inside the cavity, it isn't just the abdomen. You can look in the abdomen, the chest, the bladder, the nose, the tract that a foreign body's made. But once you're actually in there with your scope and seeing things, that's not enough. It's enough occasionally, but most often you're going to need to do something. So you do therefore need some specialist instruments. biopsy forceps, blood vessel sealers, etc. But that is an important thing to consider, that it's not enough just to be able to get in and look. You've got to be able to get in and look and actually do something useful, and that is going to need equipment. This thing called intracorporeal suturing, stitching inside the body. Terribly difficult. It's been described as trying to do surgery with chopsticks. And it is incredibly difficult, and actually the medical people, when they are describing what their skill level is to each other, if they're going for job interviews and what have you, they actually talk about how much intracorporeal suturing they've done. That's considered to be one of the major skills, and it's probably a skill that the veterinary field lags behind a little bit because we get so much less to do, but it is a skill that you actually need to develop. But because it's so difficult, you need to then weigh up, is the benefit of going in through that tiny hole, the extra time, the slight loss of accuracy when you're there, is it worth it versus, you know, might you actually be better just to open the dog up and do it that way? So you have to weigh that up. And if you're removing something, be sure that getting it out of the duck body is not more traumatic than doing an open procedure from the start. So going back to that huge tumour in the body, again, if you've gone in there laparoscopically in the first place and then suddenly thought, oh, actually I perhaps should have, I need to make a huge hole, you might have been better just making a reasonable hole in the first place instead of puncturing it all over the place with your laparoscope and then making a big hole. So these are some things, routine veterinary laparoscopic procedures. The quick look. So there are occasions when we have no idea what's going on, or we have an idea but we want to be able to actually see. And so a quick look exploratory is definitely one of the procedures that this is worth doing. Liver biopsy is another procedure where there's absolutely no doubt that doing it laparoscopically is a good thing to do, massively less traumatic for the dog, cat as well. Ovariectomy, that is something that requires a little bit of discussion, and I'll come back to that in a minute. Pancreatic biopsy, splenic biopsy, other mass biopsies. So all of these are procedures that are done wholly laparoscopically. So what we mean by that is that you have got your camera in, you've got your instruments in there, and that's all you've got. But possibly what's more common, that's a picture of a liver biopsy, are what are called laparoscopic assisted procedures. So these are procedures where you will use the laparoscope to find something out, but you will then make, generally, a small hole in order to then finish the task. So typical with these would be cryptorchid castration. Both dogs and cats can be terribly difficult to find. If you've got a dog or cat that doesn't have testicles where they're meant to be, and you know they're in the abdomen somewhere, it can be terribly difficult to find them at routine surgery. So actually, if you can go in there with your scope and you can have a look round, so you've gone in through a tiny little hole, you can have a look round, you can find out exactly where it is. And it could be anywhere between the kidney and the groin. So if you were to do that as a conventional surgery, you'd probably be making an incision that long, 10 centimetres long. You can go in, you can find it, you can then just make a little incision exactly over where you know it is. So there is no doubt that for dogs and cats with retained testicles, it is very good. Ovarohysterectomy, i.e. removing ovary and uterus. You can remove just the ovaries totally laparoscopically. If you're going to remove the uterus as well, you do need to free it up at the top end, and then you make a hole lower down and you pull the uterus out through the lower hole. So that's what's called a laparoscopic assisted procedure. Gastropexy is where you are stitching the stomach to the body wall to try and prevent the stomach prevent the stomach from twisting. You won't prevent it from dilating, but you prevent it from twisting, because there are certain dogs that are predisposed to that happening. Cystotomy is a great one, because if you've got a dog or cat, mainly dogs, with bladder stones, Again, the routine thing is to make quite a big incision, pull the bladder out, and then you have to open up the bladder, and then you take all your stones out. If you do it as a lap-assisted procedure, you go in, you locate your bladder, you use an instrument port to pick up your bladder, you then pull a small portion of the bladder out through that very small hole that you've made, and you then very carefully stitch that to the skin temporarily. You then put the scope back in through that, so you now scope directly into bladder, and you can then pull out all the stones that way. So the difference to the dog is, rather than 10 centimetre incision and a huge hole in the bladder, you've got 2 half centimetre incisions and a tiny hole in the bladder that you then stitch afterwards. You can use the same procedure for both bowel biopsies and indeed for removing foreign bodies in the bowel. You look with your scope first, you find your foreign body or the area that you want to biopsy, you literally pull that isolated section out through the smallest hole that you can, remove your foreign body, stitch the bowel back, push the bowel back in through that small hole. So there's lots of things that we can do, and it's not an exhaustive list. And then there are the much more complicated procedures. Removing the adrenal gland is not something you're going to be called upon to do very often, but you certainly can do it as a wholly laparoscopic procedure. Gallbladder removal, I was going to say sadly, I shouldn't say sadly. Gallbladders, dogs and cats tend to have massively fewer problems with their gallbladders, so it tends to be something that we need to do far less often. If you do need to do it, yes, doing it laparoscopically would be the way forward, but you don't need to do it that often. Cystopexy, culposuspension, that's a surgery that is not carried out very much anymore. It's for dogs that have incontinence, and you stitch the bladder to the rim of the pelvis. Intra-abdominal cancers, placing feeding tubes, vasopexias for when you have male dogs that have incontinence problems, and hernia repairs. All of those on that list are rarely carried out, but just are on your list. So what sort of equipment do you need to do this in practice? Well, first of all, you need this thing called the tower, which has got your monitor, your video camera processor, your light source, and this is the thing for inflating the abdomen. Very, very important that when you inflate your abdomen, that you don't just inflate it randomly. It does need to be inflated to a very precise pressure, and that little gizmo there ensures that you don't overinflate the abdomen, and it will keep it at the right pressure throughout the surgery. The other equipment that we need, which is actually all sat at the back if anyone wants to look at it later, there's this thing called the Veris needle, which is the device that you use to inflate the abdomen in the first place. You have a light cable, the tubing to inflate the abdomen, the camera, the scope, the cannulae, which are the metal devices, you can get plastic ones as well, that you use. Having made your little incision in the body wall, you then have to put these special cannulae in, so that you're not, that incision that you've made in the body wall, you're not then constantly sliding instruments in and out. That cannula then sits there, and it stops the rim of your, whether it's your camera, where the camera's going in or your instruments, it stops that becoming traumatised. If you were to constantly be going in and out with your instruments, not via an operating cannula, then that tissue would become very traumatised by the time you got to the end of the surgery, and it wouldn't heal terribly well. You need some kind of equipment, electrosurgery equipment, in order to stop any bleeding that you've got. And you do need a normal operating kit as well. So what is the cost of all of this? So for someone that wanted to set up doing laparoscopy as a vet, that kind of equipment, which is, it's in a sense the bare minimum, it's still going to cost you between 15 and 30,000. And if you wanted a few more bells and whistles, then you can just keep adding the 10,000s onto that, because there's so much equipment out there and you look at it and think, oh, I really want one of those, but it's terribly expensive. The Da Vinci system costs $1.5 million. So there is never ever, in my opinion, likely to be a vet that's ever going to get the Da Vinci robot system. So I think that, you know, the average vet is always going to be in this kind of realm. So first thing we have to do is anaesthetise, and the anaesthetic for laparoscopy is almost identical. There's only one small difference in that we don't use nitrous oxide, but that's for a technical reason. So people, again, it's these preconceptions that a keyhole procedure, that somehow you might need less anaesthetic or a different anaesthetic. It's not. It's exactly the same. You still need an animal that has no idea what you're doing, preferably. You have to clip the abdomen, and then you insert your needle, attach the carbon dioxide, and inflate the abdomen to 12 millimetres of mercury. And I put the Y in brackets to remind myself. Kat did mention it. You inflate the abdomen so that you can see things. If you, for whatever reason, lose pressure during the operation, and instead of having an abdominal wall that's away from all of the contents, if you lose pressure and that abdominal wall sinks back down and comes back in contact with all of the intestines and what have you, you can't see anything, you can't do anything. You have what's called a red out or a pink out. So all that you see is just pink. You cannot make out any detail whatsoever. So surgery without inflating is absolutely impossible. There's then a compromise to be had, because obviously the bigger you inflate it, the easier it's going to be. But if you inflate it too much, you've got to remember that you've got a diaphragm sitting there between the abdomen and the chest. And if you inflate too much, you're going to put a huge amount of pressure on your diaphragm, and you're suddenly going to have a dog or a cat that is severely compromised with its anaesthetic. It cannot breathe anymore because you've got to put so much pressure in its abdomen. And that is actually particularly important with cats. With cats, we would probably keep the pressure to slightly lower than less than 12 millimetres of mercury. And that device that I showed you that we've got, that allows you to set the pressure at whatever you want. So we then attach the scope to the camera, the light source to the scope. This is what Veris needles look like. As I said, there's some on the back. And this is the Veris needle, which is the pointer. That's the Veris needle there, in the abdomen. This is the tubing that's connected to it, and that's us inflating an abdomen. Once you've got a nice inflated abdomen, what you can then do is literally make a stab where you want your camera to go, and you put the first cannula in, and you then swap over the air to go in that cannula. So these are the instrument cannula. They're threaded. They're threaded for a very good reason. You can make a slightly smaller hole and you can screw them in, literally screw them in, and it means that you do not have this constant sliding in and out that would cause trauma. So these are very neat. Some people prefer not to use them, but most people do. So this is screwing in the first cannula. This is the scope. This is the camera. And this is the whole lot connected up. So we have cannula, that's the air going in, this is the scope, that's the light cable there, that's the camera cable, all connected up to our tower, and then I can just sit and watch what's going on the screen. We then, however, it's not enough just to be able to look, we need to be able to do. So you then make a second stab incision. It's going to depend entirely on what you're wanting to do as to where you're going to do that. So you put in a second cannula, which your instruments then go into, and you can then do whatever your procedure is. When you've finished, you deflate the abdomen. We do try very hard to deflate the abdomen as much as possible. We're very mindful of the fact that, as Kat said, in people, if you leave air in the abdomen, it is painful. We don't know if the same is true of dogs. We just make We just try as hard as we can to make sure that we don't leave any air behind. And actually closing the ports afterwards is quite straightforward. You just need a single suture in each one generally. So this is inserting the second cannula for the instruments. And then this is the same picture we saw at the beginning. So this is an intraoperative view, camera, instruments. So what are the advantages for the patient? Quite a lot. There's significantly less post-operative pain. There's been some good papers that have been written that have measured a combination of post-operative activity levels and also post-operative cortisol and glucose levels, all of which are fairly good measures of stress. And all of those parameters are significantly less in dogs that have had laparoscopic procedures. It's definitely less invasive, so we bang on quite a lot about things called minimally invasive surgery concept. So in other words, trying to do everything that you need to, but without causing as little trauma as you possibly can. So definitely reduced tissue trauma. Leads to fewer post-operative complications. These dogs and cats can return early to their normal activity levels. And there is definitely less need for Elizabethan collars and dressings because they're less likely to worry with the operation scars. For the owner, the advantages are that, again, with faster recovery times, these dogs and cats can be back to their normal selves the following day. The likelihood of there being complications associated with those wounds are significantly less. So if we consider that, say, for an operation as simple as a normal spay, the complication rate, depending upon which report you read, complication rates are up to 20% for a normal spay. A lot of people don't realise that. They think it's an absolutely standard operation and find it hard to believe that that is up to the range that we would expect to see complications. A lot of those complications are wound infections, but some of them are more serious. Complication rates for spays done laparoscopically is significantly less than that. Haven't come up with actual percentages yet, but it is considerably less. So definitely reduced self-trauma post-surgery and less nursing. So for the owner, the dog or cat can go in, have the op, come home, and they don't need to be so much thinking, I need to look after this dog. And we're finding that particularly with owners of things like working sheep dogs, that seems to have been quite a bonus for people because they've been able to get their dogs back working again fairly soon. Advantages for the surgeon, yes, of course there are some. It's actually nice to do laparoscopic surgery. It's quiet, it's gentle, it feels less traumatic, and everything just feels nicer. But more importantly, you can actually see what you're doing so much better. That's the other thing that's good about it. Normal open surgery is surprisingly blind. You can't really see some of what you're doing. And so to actually be able to go in there and look is absolutely brilliant. And we've picked up a few problems, unexpected problems, at spay. In fact, the second one that I did, the dog actually had lymphoma of the kidney, cancer of the kidney, which was a bit of a shocker, but actually at least we knew, and it wasn't then a case of doing a normal operation and then 3 months down the line the dog dying. Anyway, so it's nice to be able to pick up these other things, and because you can see your operative field so much better, the tissue manipulation is much more precise. But yes, of course there are disadvantages too. It isn't necessarily quicker. I would say now that time to do a spay is about the same, but the actual setting up of everything does take quite a long time, and I think that's one of the things you kind of have to get into. To begin with, you're so used to, with normal surgery, just diving in. You anaesthetise it, you dive in. With laparoscopy, you have all the equipment to set up first. So you've actually got sort of 10-15 minutes of setting things up before you even anaesthetise the dog. So it's a different way of doing things. I've already mentioned the fact that when you inflate the abdomen, you do have to be cautious, and if you do have a dog that's got underlying heart or breathing problems, you can cause problems. So you do have to think about that and consider if it is the right thing. And a lot of the time it is, but you just have to consider it. And we've already mentioned about adequately deflating the abdomen. The disadvantages for the owner are fairly obvious. There is a surcharge that practices will apply to any procedure that uses the equipment in order to cover both the initial cost of the equipment, the maintenance, and to reflect the enhanced skill level. Some vets will charge as little as an extra £20, but I also know that there are some laparoscopists that feel that it is such a significant skill that you're actually massively underselling that skill if you are doing it for very little. We are absolutely standard in terms of what we will charge, and our surcharge for a laparoscopic procedure is £90, which I think is a reasonable reflection of the time and the investment. I absolutely love this slide. I got both of those quotes off the internet. So the disadvantage for the surgeon. The tool endpoints move in the opposite direction to the surgeon's hand due to the pivot point, making laparoscopic surgery a non-intuitive motor skill that is difficult to learn. Or the difficulty in handling the instruments, the lack of tactile perception and the limited working area are factors which add to the technical complexity of the surgery. In other words, it's not easy. It is very different to that which, as a surgeon, you've been used to doing for years and years. So it is a very, very different skill, and it does take time. So the question is keyhole surgery better? It is more expensive. It does require additional skills. It isn't routinely offered by all vets, and I don't think it ever will be. We're the only practice in Northampton that's offering keyhole surgery at the moment. It is equally not the gold standard for all types of surgery. And I think that as a surgeon, you have to be very critical of yourself and what you're doing, and asking yourself very much, is this the right thing for this dog? But it is the gold standard for certain procedures, and it certainly is the gold standard if you want to have a look and see what's going on. If you do have a dog or cat with retained testicles, spaying, liver biopsy, chest surgery, which is actually beyond the remit of this talk, definitely. If you can do something with a scope rather than cranking open the chest, that's got to be better. Bladder surgery, we've already mentioned. So there is this list, and you have to keep that list in your mind and not just think that it's the panacea of all. So very specifically to spaying, and very quickly, it is worth saying that the term spaying is confusing. Spaying means neutering a female animal, and traditionally both the ovaries and the uterus have been removed. There has been an increasing move towards simply removing the ovaries, and there are now large numbers of papers that support doing that. There is no increase in incidence of any of the various problems that you may get from neutering. More importantly, people worry about the pyometra aspect of womb infection. You do not have an increase in pyometras. Spayed bitches that are done moving ovaries and uterus, they will only, or if you do ovarectomy, they will only develop any womb problems if ovarian tissue has been left behind. There was always this thing that if you had a bitch that had been spayed not properly and some uterus had been left behind, that there was a risk that they would develop an infection there. That will only happen if you've left ovarian tissue behind. And interestingly, you're far more likely to leave ovarian tissue behind if you're doing it as an open procedure compared to a laparoscopic procedure. Because when you're doing it laparoscopically, you can see what you're doing. And you actually check afterwards that you've got your whole ovary. And if you haven't, you go and you get the rest of it. If you're doing it as an open procedure, you can't see what you're doing. So the likelihood of leaving ovaries behind is much higher. So doing an ovariectomy is okay. And there's more information about that at the back, in fact. So it's a good, laparoscopic ovariectomy is good in young, slim dogs particularly, but it's actually equally applicable to older fat ones. Rapid return to normal activity, no stitches to remove, less intra and post-operative pain, and there's less risk of ovarian remnant syndrome, which I just talked about. But it's the same risks, benefits regarding mammary cancers and incontinence, and if people do have any questions about that afterwards, please feel free to ask. This, to my mind, is a poor candidate for any surgery. Although I did actually think after I'd written that we could probably do a gastric band on it. I think that would actually probably work fairly well. So, this, I specifically chose a Daxi. So, what I was trying to do here was to illustrate why it's such a problem spaying bitches. And it's because this is our kidney here, and the ovaries sit immediately behind. So the ovaries are just underneath the spine there, and therefore if you are entering the abdomen down here, then it's an awfully long way to go to see what's going on. The deliberate mistake with this slide, by the way, is this is a map. I'm glad somebody noticed. shows you're awake. So this again is just a couple of pictures that I got. So again, we've got ovary up here, and if we look at it, sort of looking at it, if you're looking at the, I don't know, open the dog up and you're trying to look directly down onto that surface of the abdomen, lost my pointer now, the ovary is connected by a very tough ovarian ligament to the body wall, literally, at your back here. It's also connected via a little network of blood vessels, and it's also connected by the uterus. So if you are doing that as an open procedure, you have to open up the body wall down here, and you have to pull all of this lot down here in order to be able to actually tie off all of your blood vessels. And the only way you can do that is by tearing through that ovarian ligament where the ovary is attached to the body wall. That's why ovarian remnant syndrome is more common in bitches spayed as an open procedure, because you, as I said, with that ripping action, there's more chance of leaving stuff behind. So this is what you see when you do it laparoscopically. So you've inflated the abdomen, everything is sitting there in situ. There's your kidney. That's the ovarian ligament that I was just talking about. These are the network of blood vessels, and this is the uterus. So you pick up your ovary, and then you just use some form of electrosurgery device to seal the blood vessels, and you cut through there, there, and there, and then you pull your ovary out. So everything's in situ. So instead of having to pull everything towards you to deal with it, everything is where nature intended it, and you're removing it from where it's meant to be. So it is significantly less traumatic. This is a normal spay. This is trying to find what you're finding, and it's just a very different way of doing things. Not to say it's wrong, because we do as many normal spays as we do laparoscopic spays. There's still a place for it, but purely from a purist point of view, obviously it's somewhat nicer to be able to do it in a way that seems to be less traumatic. So we do have some clips on YouTube, but it sounds like YouTube isn't behaving very well.
Might be worth trying the Laparoscopy TVC.
Right, well I will come back to that. So, very quickly, what about other species? So, I've talked about, didn't mean to, talked about mainly dogs, but actually everything that I've said for dogs is equally applicable to cats. Slightly less applicable to rabbits, interestingly, as I've said there. Rabbits have an awful lot of abdominal fat, and a bit like humans, with surgery, they tend to get an awful lot of adhesions post-surgery. So you do actually have to be quite careful if you're doing laparoscopy in rabbits because of that fact. Doesn't mean you can't do it, you just need to be more mindful of it and try and be as untraumatic as possible. Cats, it is considered to be the gold standard for finding retained testicles in cats, which I can fully believe, because sometimes trying to find retained testicles in cats can be an absolute nightmare. So much better doing it that way, and definitely things like liver biopsies, brilliant in cats. Horses, it's a huge area that's being developed currently. And mares get quite a few problems with tumours on their ovaries, so doing ovariectomies on mares, doing liver biopsies, finding retained testicles, all increasingly being used in the horse side of things. Interestingly, there is a big gold standard use in farm animals. Cows get something called displaced abomasum, where their stomach goes around onto the wrong side, and getting it into the right place and stitching it in the right place using laparoscopy to see what you're doing has now become the gold standard for that as well. So that's quite an interesting one. And of course there's masses and masses of zoological applications, and the reason why in zoo work is because they actually need to get those animals off the table, and they don't want to have to anaesthetise them, they don't want to have to examine them afterwards preferably, so they need to have a procedure that they can do, and those animals can go straight back out to where they're needed to be. This is again just illustrating with a horse with a huge amount of intestines and everything else that you have lying around. Again, your ovaries are up here, so that's why laparoscopy is pretty good in horses, because you're trying to get to an incredibly inaccessible region.
Can I just ask a question about that?
Yeah.
It relates to also the one that you showed about the dog. It's when you do the laparoscopy to say do the ovaries, do you go in through the side or through the
midline underneath? So the most normally used sites are just behind the tummy button and just in front of the tummy button. So you put your scope in just behind, and your instruments just in front, and that's the most common place to, and you can generally survey and do an awful lot from those two ports.
In a horse you're going on the side, don't you?
In horses you're going in the side, sorry, in horses you're going in the side. The future for veterinary laparoscopy, and opinions vary a great deal. There's two chaps in the veterinary world that are sort of equally preeminent, and they have wholly opposing views. So one of them says very much, just because you can do it doesn't mean to say you should. And the other one is saying, oh, it's the next thing, you know, everyone will be doing it soon. And I don't think that either is true. I think there is a place for it, but it's not readily accessible for most vets, and I think it will remain a specialism. But equally, I do think there is very much a place for it. I think there are an awful lot of gold standard uses for it, and certainly from my point of view, from what I've seen, the ability to look at things, to do things, to get a dog or a cat back on its feet, to do a diagnostic procedure that you don't feel that you've done that animal a disservice by trying to find it out. So things like liver biopsies or even bowel biopsies, you hesitate hugely if you know you've got to do a great big open procedure and you think this animal is going to take a while to recover from this, and do I really think it's in this animal's interest to do it? If you can do something through a very small hole that the animal is going to tolerate significantly better, and the outcome can be enhanced by doing it. That's where I like it. That's where I think its place is. It's the fact that I want to try and do the best for the animals that I'm entrusted with the care of, and if I think that I can do that better by going through a small hole, then I'd like to be able to do it. And this is why we went into it. It was because of a belief that it had a merit. So we can watch some clips. We can watch some really amazing ones called chest ones, removing the outside of the covering that's around the heart, but that's very, very specialist. I think probably we should have a look and see what a spay looks like and hope that YouTube doesn't let us down. So if we just go back a couple of slides, it's not going to happen.
How does an insurance company
I haven't had an insurance company reject a claim at all. Obviously spays aren't normally covered with insurance anyway, but when we've been doing it as part of a diagnostic thing, and actually interestingly with that, let's take say something like a liver biopsy, we talk about this £90 surcharge, but actually your surgical time for liver biopsy is significantly less. So it is a little bit swings and roundabouts. You haven't heard any problems with...
And in fact for retained testicles, if it's something that's not, if you take out insurance before it's been noted, then the insurance company will actually pay for the difference in price of having that procedure.
Right, I'm going to struggle with this, I think. Yes, I am. Right. Okay. So we had a soundtrack on this, which unfortunately was us talking, so we had to get rid of the whole thing. Then we thought we'd put music to it. So this is that's the equipment that I was talking about that's on the back table, and that's inserting the needle to inflate the abdomen with air. And that's it busy inflating. Trying to be a neat surgeon. That's making the stab incision, putting in the scope cannula. And then we insert the camera and so that's the image that we see as we go in. So we've got the liver and the gallbladder sitting there, and then we come round, that's all just large intestine that's sitting there, all that pink flobby stuff. As you come around the back, that's the bladder. Then we go around the full circle, that's the spleen just come into view. And then we come back to see the liver. So we always survey the abdomen before we do anything. And then that's now with the both cannulae in. This is securing the ovary to the body wall using a needle and suture material. So you secure it, you push it up against the body wall from the inside, and then you suture from the outside. So you can see the stitch that's going through from outside, and that's now suspending it. We're now burning through the blood vessels. Until we are finally left with just a little ovary sat on the body wall, and that's just looking at where it was all removed from, so no bleeding whatsoever. Now we're doing the other side. Same thing, that's the needle coming through from outside. That's the kidney that you can see sitting there. And now we're going to grab the ovary and we're going to pull it out eventually when it reloads again. So if we watch the picture on the left, we can see the ovary popping out through the hole. There we go. We couldn't think of anything else to use to give a size idea apart from my thumb. So we're left with two tiny little holes, which we then stitch, and then those were the holes, that's the dressing. That's her recovering from her anaesthetic, and that's 90 minutes post-op. So that's why I like it.
Helen, that's clearly a young bitch. Do you still recommend that they have the first season?
No.
Does that not increase the incidence of incontinence, or is that a fallacy that I've grown up with?
Yes and no. So the two main discussion points regarding timing of spaying are mammary tumours and incontinence. So mammary tumours, if you spay prior to the first season, then the incidence of mammary tumours in later life is very, very low indeed. If you spay between first and second season, that increases to 8%. If you spay after the second season, then the incidence is around about 25%. So 1 in 4 bitches are going to get mammary tumours if they aren't spayed early. If you put that against the incontinence story, there's a huge number of papers and there's not a huge amount of consensus agreement, but overall it is said that anything up to 20% of bitches that are spayed early, or that are spayed, will develop sphincter mechanism incompetence. That incidence is massively lower in bitches that are unspayed. Okay? If you look at the figures of bitches spayed before the age of 3 months, the figures are very, very high. After 3 months, the latest figure that I read was 5%. So if you compute all of that, however you compute it, it does actually come out that spaying somewhere between 3 and 6 months, i.e. before the first season, yes, there will be an incidence of sphincter mechanism incompetence, but what you lose on that, you gain in spades on not having mammary cancers.
Would this procedure help eradicate that?
Doesn't make any difference. It makes absolutely no difference, although there's not actually really any long-term studies that are showing anything. One of these things about the sphincter mechanism incompetence in bitches, no one really knows why it happens, and I think that's quite a problem. So over the years there have been theories, or hormones play a part, but it's also much more common in docked breeds. It's also much more common in certain giant breeds. So we know that there's a genetic component as well. We know that poor surgical technique can also contribute hugely. And I'm sure this is one of the reasons why when you read all the various papers that have been written, you can't get a good consensus between all the papers as to the exact figures. And I'm sure that at some stage someone will come out with figures from just doing ovariectomies, and I don't know what it will show. Do you have anything to add to that?
No, not really. I just know there was a very big, just to answer Mark, there was a huge study in the sort of early 2000s about the sphincter mechanism incompetence looking in the States, where they've been spaying bitches before the first season for absolutely ages, and there wasn't overall an increased incidence in urinary sphincter mechanism competence compared to countries that spayed after the first season. So I think overall, jury's out a bit. And like I said, I think there's other genetics playing a role here. But yeah, as far as just ovarectomies, I'm not sure. But yeah, those studies are in hand, I think.
Any other questions?
How long does the operation take?
Surgical time, all things being equal, the amount of time that the dog is actually on the table is going to be something in the region of between 20 and 40 minutes.
And this I'm doing.
How does that compare to the open up?
Pretty much identical.
Yeah.
And again, that's not just us, the papers that have been written. They've generally shown that the laparoscopic procedures were on average 1 to 2 minutes slower than an open procedure. But it means, I mean, that's really not that statistically significant. It's about the same.
And probably we'll get faster, but it's all the kit as well, kit factor.
When you say that you try and remove all the carbon dioxide, are there not, thinking of carbon dioxide detectors, is there not a detector that you can put in to actually determine whether it has or been removed?
I'm sure you could. It's difficult to know how relevant it is in the veterinary world because I have yet to see an animal that is lame after a laparoscopic procedure. So it's hard to know how much of a problem it is. As I said, it is this frequently stated complication in people, and I would have thought that it would be something that could be usefully used in people. Maybe it is, I don't know the answer to that.
Well, one final question, as an interested party, having had a number of arthroscopies
Yes.
over this year,
Yes.
I didn't realise that arthroscopy related purely to joints,
Yes.
if that's what I understand. So am I understanding that you're not doing arthroscopies?
Right, so interestingly, one of the reasons why we got into this in the first place was because actually we had half the kit already, because all of the oscopies are indeed related. So we have flexible endoscopes which enable us to look down in stomachs and up other places. That all connects up to this equipment. We do actually have arthroscopy equipment. That was actually why we had a lot of this in the first place, because to begin with, that was what we were going to do. But the learning curve for arthroscopy is, if anything, even steeper than for laparoscopy. And it's one of those things of being in the right place at the right time. So back to my bit of, you actually always want to do the best for an animal regardless of your own professional sensibilities. If you know that there is someone out there who can actually do arthroscopy massively better than you because they've been doing it for way longer, you're going to refer to that person. You're not actually going to do it yourself. The only time that you might be tempted to do it yourself is if you have a client, if you have a definite clinical need and you have significant financial constraints. So yes, we do have arthroscopy. Yes, we do it on a very limited basis. I suspect that we might start to do more now that we're doing this. The laparoscopy is much more new. There isn't anybody out there doing it any better than we're doing it. Well, that's not strictly true, there are, but they're not many. So most of the people, even at some of the referral centres, are not doing that much more than we are. So it's a much, much newer specialty. So we're much more getting into it on the ground floor. We missed the boat slightly with the arthroscopy.
We don't see as many cases that need arthroscopy. Cases, spays and things that need laparoscopy come through our door every day. Cases that need arthroscopy don't. We shall see.
But in the short term, certainly we would continue to refer. Well, thank you very much, everybody, for coming.
Thank you very much.
It's been